organization. We were able to organize it in a year, in 2 weeks, because we got tremendous amounts of help from people around the world. I'd written an op-ed in the Wall Street Journal calling for a study like this, and was immediately met with offers of test kits, resources, people volunteering. It was actually quite. It felt like the community was coming together to answer this question. And one of the things that happened was we were wondering how we should sample the population of Santa Clara County. We debated between a few methods. It was very difficult to get in the time of a lockdown a representative sample in the normal way. And so we decided instead we were going to do this. We landed on this Facebook recruitment technique, where we essentially invited a random set of people on Facebook. We knew that it was going to lead to relatively well-off people volunteering for the study. In fact, a very large number of Stanford faculty wanted to be on the study. I got emails from Stanford faculty asking to be on the study. In fact, that's exactly what happened. We got a lot of people around the richer parts of Santa Clara County signing up, and the poorer parts of Santa Clara County were underrepresented. We know now that meant probably an underestimate of the prevalence, because richer communities were protected from COVID relative to poorer communities. But I know if that's true in your studies in India, but also turned out to be true in many, many places in the United States. We did some statistical adjustments, which I think people are still fighting over. But the paper is published and now has been replicated almost 100 times, including your study, in terms of what the infection fatality rate is. Worldwide, it's squarely in what the range of what other seroprevalence studies are finding. Something on the order of 0.2% in April of 2020. Now, this was a community dwelling population, so it didn't include places where there was high fatality, for instance, in nursing homes. So that wasn't in our sampling frame. So it's not surprising that it's 0.2 and not say 0.4 or something. In LA County, we had a very different approach. We sampled based on we hired a professional firm that had an existing representative sample. And we sampled that population using that existing representative sample as opposed to this more Facebook sampling scheme, and came to almost exactly the same answer. 4% of LA County prevalence, 0.2% infection fatality rate. And so we were, in many ways, we given the short time frame, I think we were very, very careful. We got a tremendous amount of reaction to the study, including something on the order of and I know this will horrify even you, Anup, 1,000 referee reports within the course of 3 days, publicly. People emailing me from around the world with errors they found. The initial version of the study had a statistical error in the calculation of the standard errors. We released it as a preprint, the Santa Clara study. And preprint is not peer reviewed. It's meant to generate comments and suggestions from scientists, which is exactly what happened. In that sense, I was happy. It's never fun to get 1,000 referee reports, as you can probably attest. But it was really productive, right? So we corrected the statistical error. We got a very large number of people in labs around the world giving us evaluations of the test kit that we used, negative and positive control samples. So we got a much more precise estimate of the false positive rate and the false negative rate of this test kit as a result of this sort of worldwide evaluation of the study. And we released an updated version a week later, correcting the statistical error, incorporating the vastly expanded set of evaluations of these test kits. And the result hadn't changed. Like the standard errors were slightly larger, but the point estimate and the fact that it was a very large fraction of the population stayed true, even at the end, even after the corrections, and was published later in the International Journal of Epidemiology. That Santa Clara study, the LA County study was published almost immediately in the Journal of American Medical Association. You asked one other thing, which I think is also important to address, like what was my preconception about this in the study? Now I have to admit, I did have a preconception. I thought that the prevalence of the disease was more widespread than people were saying at the time, or at least it was possible that it was more widespread at the time. That's one of the main reason I was interested in conducting the study was to resolve whether that preconception was correct or false. And this is just a small anecdote. On the eve of the study, the lead author, Eran Ben David, another author, Niraj Sood, both former students of mine, and I made a little side bet about what we thought the prevalence would be. And Eran thought it would be 5%. Niraj thought it would be 10%. I initially came in with 11 just to win the bet, but then the Niraj forced my hand. I said 20%. When the result came out to 2.8%, Eran won the bet, and I now believe it was 2.8%. I think that's how you learn, is by doing this kind of work, updating on the basis of evidence. Preconceptions are normal. Usually we call them hypotheses in science. There's nothing wrong with that, as long as you update. And after the 2.8% came out, you want to know what I think the prevalence was in Santa Clara in April of 2020? I don't no longer think it's 20%. I think it's 2.8.
So, but sitting on the outside, so I was sitting in Chicago when you were doing the study at Stanford, and I followed the back and forth in the academic literature, but I was also following the back and forth more broadly. And I was really surprised by the amount of political vitriol directed at your study, which is really surprising. Me personally, it led me to decide, hey, let's not work in the United States, because you don't know if research might be politicized. I'm going to go work in India, where people, I'm less attached to the consequences, perhaps because I'm so far away, and maybe it'll be less politicized. And so my takeaway from your study, beyond updating my prevalence estimates, was to say, hey, research in COVID is going to be very politicized. And that's what I thought for a long time. But at the same time, as I looked at what people were doing research on, I found that the people are actually saying a lot of, and publishing a lot of unpopular things. So for example, if you look at the economics research done in the first 6 months of the lockdown and its effect on, say, economic activity, there are a lot of famous economists, Austin Goolsbee, Raj Chetty, Matt Genskow, showing a lot of voluntary distancing and very small effects of lockdowns. John Ioannidis, who's one of your co-authors in Santa Clara, has been criticized for his skepticism about high infection fatality rates, but he still continues to publish. I mean, there are a number of papers he's written during COVID. And you also see, on the other hand, people that publish studies that are consistent with the dominant storyline, let's say. So, for example, Doubledave's paper on the South Dakota motorcycle rally and the super spreader event there, that study was criticized by many for being poorly done. And so it's possible that maybe the concerns about politicized research are overblown. And then, in fact, what people are worried about is just bad methodology. It's not about political motivation, but actually bad methodology. I want to see where you lie on this. Do you find other example situations where people have avoided research because they're worried about political consequences? Or do you think that basically the research literature is kind of getting it right in going after the poor methodology papers as opposed to the good methodology papers?
I mean, science always takes a while to sort out what's right, what's wrong. And there absolutely needs to be an environment where people should feel emboldened to take stances that are not consistent with the zeitgeist. I think in large part, the scientific literature has failed at this during the course of the epidemic. While you can think of examples of people who have pushed the other way, generally it's come at high cost to the people that have pushed the other way. You can talk to John Ioannidis, for instance. He wrote a fantastic essay in Tablet describing the smearing attacks that he's faced. I personally have gotten death threats throughout the pandemic, even from the Santa Clara days when I was just doing science and had appeared on TV. A lot of the people that have worked on in this area have commented to me about how difficult it is to publish results that run counter to the pro-lockdown narrative. People have lost their jobs, forced out of their jobs. People have lost grants. People lost opportunities to collaborate as a consequence of their of scientific results. Now, you can go talk to, for instance, Gabriela Gomez in Scotland, for instance, about that. You can I can give you names of many scientists that have faced essentially career harm from findings that they have in their scientific work. And it's asymmetrical. I mean, you give examples of people who were, a couple examples of economists, but I'll tell you, as a general matter, it is people that were finding results that were inconvenient for the lockdowns that faced this kind of pressure. Another example, the Danish mass study, right? So the Danish mass study was a study that was conducted in Denmark, a randomized trial of masked in Denmark, 2,500 on each side of masked and unmasked. They found a null result and found it very difficult to publish as a consequence. This kind of asymmetry in favor, whereas like almost immediately after the lockdowns were implemented, anything that looked like the lockdowns were working got published in the top quality journals, regardless of methodological problems in the studies, right? So for instance, there were these evaluations of whether lockdowns worked that used as a counterfactual these SIR models as opposed to a real world counterfactual, and then assume that any deviation from the SIR model must be attributed to the lockdown. I mean, that wouldn't pass muster in any setting, and yet it was published in Science, right? So there was, I think, in the scientific literature, and you can see this continue to this day. You have the editor of Science publishing on Twitter an attack on Dr. Scott Atlas, calling him evil, and by extension me and the authors of the Great Barrington Declaration evil for proposing a focused protection approach. The editor of Science magazine. You have the head of the NIH, Dr. Tony Fauci, calling me a fringe epidemiologist in writing, essentially to send a signal and calling for a devastating takedown of me personally and my ideas. That is not a neutral scientific environment. It's created a scientific environment where if you come out with a result that is contrary to the reigning narrative, you will be attacked. And that is an absolute fact. I've seen it personally. I have countless emails from scientists around the world who've told me about their experiences as well. It has been a absolutely, like the landscape of trying to do science in this environment has been almost impossible unless you come out with a result that the reigning pro-lockdown narrative agrees with.
So I want to pick up that thread. As you pointed out, there's the risk of not just publication bias that we had before COVID, which is bias not to publish studies that are finding zero results or null results, causing the literature overestimate the effect of various interventions. Now it seems that there might be a political bias in publication as well. And I want you to talk a little bit about what the consequences of that are. Because on the one hand, we hear things like trust the science. And maybe that really means trust the political judgments of editors. And that can be a little bit problematic. What do you think the long-term consequences of this is going to be in terms of trust of the academic product that comes out of these journals?
Well, I think during the pandemic, let me just talk about the United States because it's a little harder to discuss it worldwide because it's world, but I think similar dynamics are happening worldwide. In the United States, you saw journals, including I think the New England Journal, come out in like major journals, Science magazine, come out in favor of with endorsing a presidential candidate. People looked and saw. During the BLM riots, thousands of epidemiologists who just 2 days ago had been saying, no, we need to stay locked down, say, no, protests are okay if they're the right protests. The left-leaning academics who essentially thought it's okay to very strongly embrace their ideology in their public utterances, even when it ran against their previous public utterances, I think that that what that has contributed, and then I'll give you another example. Is I did a House testimony in summer of 2020 on the evaluation of the safety of the vaccine, and you had during that House testimony there were several academics on the other side who, sort of highly qualified professionals, including someone who previously ran the group at of biologics efficacy and vaccine efficacy in the FDA, questioning the ability of the FDA to evaluate the safety of the vaccines from the left. And then the Joe Biden wins, and all of a sudden the narrative shifts on a dime. That kind of politicization, the one-sided politicization, essentially is and then I've been on CNN, I've been on Fox, and I get grief for going on Fox because I'm when I tell people on Fox that the vaccine is a good idea, that I shouldn't be doing that, just ipso facto because I'm on Fox. I think this kind of politicization by academics has contributed to at least half of the American population instinctively distrusting both public health and science. I think it is absolutely disastrous for science to have this one-sided political orientation. I'm almost thinking about this as like the Catholic Church. You have to be a celibate in order to become a priest. I think it would be better off as an equilibrium for scientists to take a oath of political celibacy, if at all, if you want to enter public health or science, because this kind of one-sided political leaning effectively means that, and where you actively display that political leaning in how you comport yourself, where you actively disdain the other side, automatically is going to make the other side distrust you, no matter what you are saying.
I want to push back a little bit on that. So I agree with you that I worry, like you do, about politicization of science and the oppression of it. But the argument, there are two sides to this argument. On the one hand, academics have the right to political speech as well as non-academics, and on the other hand, they also have to live with the reputational consequences of it, which is that when people are suspicious of their results because of their political views, that's necessary. I mean, that's not necessary. It's expected. And so there are two sides to this, and they get to choose. But I think the thing that's unrealistic about what you're suggesting, that the claim to, like a requirement of celibacy on the part of academics, I think that's unrealistic. You're not going to get modern research scientists, academic professors, not to take political sides. How about an alternative? You should be required to post whether you're Republican or Democrat, or don't vote for either on your papers. Is that a better idea? I would contend.
I mean, I've never signed up for a political party for the reason that I fully wanted to be able to talk to both sides. I mean, because I'm never able to, as I've already confessed, I'm very poor at predicting the results of the outcomes of what my papers are going to show. And whatever the result, I want to be able to tell people about it and persuade people about it. I don't know necessarily that just revealing that you're a Democrat or Republican automatic, because I think the default of most people reading academic or listening to academics is that the people think that they're Democrats or left wings. I mean, that's just the default, just by the fact that the conservatives are essentially not represented amongst most academics. So I don't think necessarily that would solve the problem. I do think that you can have it be fully Democrats. I don't actually think that the party affiliation or even the passions that academics have about politics are really the problem. The problem is that they actively disdain people on the other side. That lack of respect for the other is at the heart of the collapse in trust in public health. If you had an academic sort of environment where people have their politics, but they look to the other side as fellow humans that sometimes are right, sometimes are with foibles, their side also with foibles, you would have a much more active level of trust, both in public health, which is also dominated by left-wing academics, and in science than we currently do. It's less the political slant of the people in it than the active disdain by people in it for the other side who do not share the political views.
All right, so let's continue that part of the conversation, though. You and I have spoken on and off during the course of the pandemic. We've talked about research that you've done, research that I've done, and one of the interesting things that's come up is your experiences at Stanford. That is to say, your interaction with the university itself. A really important topic, I think, for those of us in the academic profession is academic freedom. Can you tell us a little bit about your back and forth with Stanford, the various efforts of professors and students there to get you fired because of your political views or because of your study? Tell us a little bit about that, and then I want to ask. I know you survived, so I want to ask: did you survive because you're tenured and well accomplished, and what would have happened if you weren't?
So I think Stanford has failed in its commitment to academic freedom, at least in the way that it's treated me and several other people at the university who have stood up against lockdowns. It started before I was standing up against lockdowns during the regulation of the Santa Clara study. The Santa Clara study, as I said, we organized very quickly with the cooperation of the Human Subjects Board at Stanford, with the cooperation of Santa Clara Public Health. The way that the university reacted to the study violated standard norms of how research is regulated. It's absolutely appropriate that Human Subjects Committee comment on and cooperate with the conduct of a study that involves human subjects like we ran. And for instance, the sampling scheme was cleared by human subjects. The script for how to return the results to patients was cleared by human subjects. All of that was cleared. After the fact, after we ran the study, after it became clear that it was going to gain a lot of public interest, and it was not necessarily going to be something that would favor the kinds of policies that we've been following, the implications of the study, Stanford organized what I've been calling a star chamber, a group of ad hoc academics, Stanford meaning like the dean of the medical school, organized a group that forced us, for instance, to redo all. So we had 3,000 people roughly in the study, 50 positive results. They forced us to bring back in all 50 people because there was a pathology group that wanted to make their own antibody test, that was very upset that we're using a different antibody test than they had. They hadn't yet made it. They wanted to use it for sale. They forced us to bring all 50 back in and retest them, all 50 positives back in and retest them. This was forced after the fact, not by human subjects, but by this ad hoc group. When the result came back that the false positive rate for the test was exactly what we thought, 0.5%, the pathology group ordered us not to reveal that result when what was at stake publicly was that the false positive rate was too high. Well, we had now an independent confirmation that it wasn't too high. And Stanford agreed then with the pathology group that we shouldn't say anything about it. I've mostly stayed away from the fight at Stanford because I didn't have the emotional bandwidth to fight both Stanford and also this sort of wider fight. And I thought the wider fight was more important. But I do think that Stanford has done another example of Stanford acting sort of in ways. It's essentially become a hostile work environment for people like John Ioannidis, for me, for Scott Atlas. 100 faculty at the medical school, organized by the former dean of the medical school, wrote a letter attacking Scott Atlas when he was advising the president of the United States, essentially saying lies about him, saying in effect that he didn't support hand washing, which was not true, or that he didn't support masking. Well, he did support masking in places where it might make a difference, for instance, nursing homes and other places where vulnerable people lived. I think rather than engaging, they've worked very hard to smear. Another example is that there were a group of faculty in epidemiology who circulated a secret petition to the president of the university trying to get me silenced because I had spoken up at a roundtable with the Florida Governor DeSantis, saying that on balance, the harms from child masking probably outweigh the benefits. I think this kind of and then there was a public, essentially a postering campaign around kiosks around campus with a picture of me giving testimony in front of Governor DeSantis during the summer wave this Delta summer wave in Florida, effectively trying to accuse me of somehow spreading the disease when in fact it's very clearly a seasonal disease and it's very difficult to stop from spreading. They posted these posters near a coffee shop where I happen to always go. I mean, for a couple of days, I just stopped going because I actually feared for my safety. I called, and Stanford did nothing. I think this is one of these things where the response of Stanford has been extremely irresponsible to maintaining the environment in which academic can sort of practice their craft, especially if they didn't agree. And I think Stanford's likely going to need to have some. I mean, I don't know. I don't have a ton of confidence in it, but if it wants to maintain its commission as a place where academics can happen freely, it's going to need to rethink how it approaches academic freedom because it failed during the pandemic. You ask, how did I survive? It absolutely has to do with my tenure. There are lots and lots of younger faculty who stayed in line, signed these petitions because they didn't have that protection. I've heard from young faculty who felt like they faced pressure to sign these kinds of, for instance, the letter against Scott Atlas and other petitions, in part because what are they going to do, right? Their senior colleagues, in essence, are saying this is a political litmus test. And I think that is that's something that again, I think we're going to need to think about carefully. I think that to me has been less important than the lockdown fight. The lockdown fight's way more important to me because I think that it's harmed so many people around the world. But it is something that I think the local fight is a reckoning is going to need to happen around that local fight.
Okay, so I agree with you that that academic freedom is an important fight, but that the fight over society-wide policy is more important. So let's turn our attention to that. And let's jump right into the Great Barrington Declaration and targeted lockdowns. So there are two views of GBD. One is the charitable view. What you do is you oppose widespread, broad lockdowns that are indiscriminate, and you're okay with narrow lockdowns or protections that are targeted at the most vulnerable, to protect the most vulnerable, for example, the elderly. Now, there's a skeptical view of the Great Barrington Declaration, which is that the vulnerable are too interspersed in the population to be protected in any focused way. Moreover, GBD has embraced herd immunity for the non-elderly, and COVID has, while it's much higher cost for the elderly, it is sufficiently high cost for adult populations that's just very bad policy. How do you respond? How do you explain to people can you explain to people what you think GBD really is with respect to lockdowns? And can you give us a sense of what the feasibility of the policies in the Great Barrington Declaration? Are there any countries that have successfully done targeted protection or targeted lockdowns? Is it really an option for many countries where even the elderly are interspersed because of multi-generational families?
So the GBD, we wrote it in an environment where the supposed scientific consensus was the only approach to to addressing the epidemic was widespread lockdown. It was October of 2020. The talk of lockdowns were coming back, and in fact, lockdowns were imposed in many, many, many countries shortly after the GBD was written, including the United States. School closures, business closures, church closures. In many places, additional stay-at-home orders, quarantines, mass asymptomatic testing, forced sequestration of populations. A lot of that was coming, had already happened in the spring, and was coming again. The question is not whether there's a perfect policy that would produce no deaths. That was not in the feasible set. The question is, what's the right policy in face of the scientific evidence? The central scientifically important point that motivated the GBD was the very large spread in risk of mortality. almost 1,000-fold higher mortality, more than 1,000-fold higher mortality risk for older people relative to younger people. The GBD actually is not even a radical policy. It's the same policy that we followed in pandemic after pandemic going back 100 years, right? The 1959, 1968, 1976, even 2009. For respiratory pandemics, this idea of focused protection, finding who's most vulnerable and working to protect them, then is actually was a call to a return to standard pandemic policies rather than this radical policy we have been following of lockdown. And the question is, what's the aim of that policy of lockdown? In effect, you can see this, what happened with the GBD, the counterattack to the GBD afterwards, to the extent there was an intellectual counterattack. The intellectual counterattack focused on two ideas. One, zero COVID, that in order to get things to normal, we needed to suppress the virus down to zero, eradicate it, and then things could go back to normal. A massive movement formed around that, the zero COVID movement. Closely related to that was this idea that there was no immunity produced after infection, and therefore this is unlike any other respiratory virus we know of. It's unlike any other coronavirus. It's unique. And so you get infected and you get infected again and again and again, almost immediately, as if you never had an immune response, right? That was the heart and soul of this, for instance, this Lancet John Snow memorandum, signed, for instance, in particular by the CDC director, the current CDC director. A shocking fact that the CDC director doesn't understand the basic science around this or the epidemiology around this. So what happened was you had this counterattack not rooted in science, painting a false alternative, this utopian false alternative, saying, oh, well, it's irresponsible to say that we have to protect the vulnerable while letting people live their normal lives, because that's the sum and substance of GBD. What we instead need to do is this utopian policy with a lockdown, violating the rights of millions, harming the health of tens of millions. 100 million people thrown into poverty worldwide, 80 million people thrown into dire food insecurity, hundreds of thousands of children dead from starvation in poor countries, health harms for cancer so people with cancer in the United States because they delayed their cancer treatments and their cancer screening, diabetes management, heart attacks, psychological harm on a level I don't think we've ever seen before. 1 in 4 young adults seriously considering suicide in July 2020. All these harms we should just ignore in focus in favor of the goal of eliminating the virus. That was the alternative. Instead of what I had actually hoped with the GBD was a conversation with people in public health about how best to protect the vulnerable, given the constraints we had. When we wrote the GBD, we wrote a number of suggestions, which we hope to be as conversation starters, how to better protect patients in nursing homes, because that's where 40% of the deaths were at the time, still quite high fraction of deaths. How best to protect people, for instance, in older people living alone in the community. Well, why didn't we organize food deliveries during times of high community transmission to them instead of food deliveries to the rich and the laptop class? We could have for people living in multi-generational homes, we could have offered hotel rooms or other places to stay when someone in the house comes home and says, "Oh, I might have been exposed," or calls and says, "Grandma, I might have been exposed." Well, then we should have adopted a wide suite of policies, and those would have been local policies because it depends on the local living circumstances of the population. It'll be very different in South Central LA than it will be in rural Montana. Local public health, we hoped, would engage with us in thinking of better ways to protect the vulnerable. Instead, what you got was propaganda. It was a propaganda lie to say we were proposing to let the virus rip. We talked about herd immunity because what else ends the epidemic other than widespread immunity in the population? Instead, we got propaganda that there is no immunity in response to infection. We're not arguing for herd immunity as a strategy. That ends the epidemic, whether you do lockdown or if you do focused protection or if you let it rip. We were arguing against letting it rip. We were arguing for focused protection. We were arguing against lockdown. We were arguing for focused protection because the lockdown was so harmful to young people, to populations. We're still doing it. We're still closing schools today, Anup, in the United States, harming children for no purpose in terms of disease spread based on what the science has shown. The disease is going to spread very clearly despite those interventions and are going to impose harm.
Yeah, I want to get back to schools in a second, but I want to pick up a comment you made earlier on that your goal with the Great Barrington Declaration was to start a conversation. That wasn't the perception, but what I want to talk about is recent news associated with that topic. So recently it came out, an email thread or an email exchange came out that involved, I think, Dr. Anthony Fauci and Dr. Francis Collins. And both of them seem to suggest that the government ought to discredit the supporters of the Great Barrington Declaration, including yourself. Some interesting comments about you and your background and whether you're an accomplished academic. But let's put that aside for a moment. There's a charitable view and an uncharitable view of that email chain, and I want you to comment on it. So the charitable view is that it was just an emotional response, and that nobody in the government really acted on it. It's like the canonical case of why people tell you that when you're angry and you write up an angry email, you should wait 24 hours before you send it, something like that. And they violated that rule, but really they didn't do anything about it. A less charitable view is that no, they did something about it, and there were efforts, maybe obvious or not obvious, to discourage dissent. And while that strictly isn't a First Amendment violation to say, hey, you should say some bad stuff about people that are criticizing the government and government's response, it really raises questions about whether or not the government was going after dissidents in the context of COVID policy. So I kind of know what your answer is to which view is correct, but I want to give you a little bit of airtime for that. But what I really was hoping you'd comment on is what is the implication of this email? On one hand, was it just ignored? It's not a really big thing. It really hasn't affected people's opinions, or is it that it's affected people's trust in whether the government is thinking about all aspects of COVID policy before making a judgment?
So just one piece of evidence on whether it was just an offhand email written in anger. Francis Collins gave an interview on Fox News last week or the week before, doubling down on his views, calling me a fringe epidemiologist, Sunetra Gupta, a fringe epidemiologist, that Mike Levitt, the Nobel Prize winner who signed the Great Barrington Declaration, a fringe epidemiologist, Sunetra Gupta, professor of theoretical epidemiology at Oxford University, fringe epidemiologist. This is not something that was simply written in anger. It was a coordinated policy by the government, and by the way, there's evidence that the UK government participated to discredit the ideas of the Great Barrington of focus protection, but not to discredit it in any reasonable way by engagement with the ideas and producing evidence against it, but rather by engaging in a propaganda campaign, by calling it a let it rip. The reason why you said, one thing you said was interesting was that wasn't the view at the time. Well, the reason it wasn't the view at the time was because of this propaganda campaign. It wasn't the view at the time that we were calling for conversation, because it was immediately characterized within days of our writing it as a let it rip strategy. Well, the words let it rip do not appear in the Great Barrington Declaration. When reporters first started asking me about let it rip, which is just just a few days after we wrote, I was really puzzled. Like, where did this idea of let it rip come from? It wasn't something I had said. It was not an idea I even had. And yet we had reporters from the New York Times writing this, Washington Post writing this, all these establishment newspapers essentially parroting the rhetoric that you find in that email by Francis Collins to Tony Fauci. And it was, they were calling for, and then if you look at subsequent emails that were released by FOIA, by Collins and Fauci, they were, I think, seeding these stories in the press. In fact, you could see them sharing press stories from like The Nation magazine and Wired, parroting their line. And I don't know how exactly how the sausage gets made. Frankly, I don't really care. It's not the role of the NIH director to organize a media campaign or a propaganda campaign against a rival group of scientists. It's not his role to discredit those scientists with ridiculous things about fringe. I mean, frankly, I'm thinking of putting fringe on my as a term of pride on my business card. I think this is one of these things where, like, in place of an argument, they just had invective and they had propaganda, because they really didn't have an argument. They couldn't say, no, don't do focus protection, because that's ridiculous. Of course you should do focus protection. They couldn't say that the lockdowns were working, because of course the lockdowns had not worked. And they couldn't also say that the lockdowns weren't devastating, because they were devastating. What other arguments did they have? And they resorted to illegitimate means to try to discredit us. I'll say one other thing about this, having to do with related to your second question. This is a conflict of interest, a deep conflict of interest, that you have the funders of science, in effect, setting public health policy. That means that anyone in public health or in other fields that are related to public health that want to speak up against the public health policy are going to need to think twice. Well, what's that going to do to my career? Will I ever get another NIH grant again? It creates a conflict. It itself is a conflict of interest for Tony Fauci and for Francis Collins, but it also creates within the scientific community at large a widespread conflict of interest, where scientists have to decide. Many scientists have written me saying, I haven't spoken up because the environment is such that I fear for my career. That was a legitimate fear. It created this setting where you had a group of essentially lackeys who were like perfectly happy to parrot the propaganda. And then you had a very wide number of scientists who were afraid to speak up because they were afraid that their careers were on the line if they spoke up. The fact that the head of the NIH could take on himself such a role is an absolute scandal. There needs to be a bright line, I think, between the funders of science and the setters of policy.
Okay, kind of the topic that was at issue in those emails is lockdown. So I want to turn to lockdown. It's also a central issue in both the Great Barrington Declaration and a website that you created called Collateral Damage.
Collateral Global.
Yeah, Collateral Global. Sorry, collateralglobal.org. I want to talk a little bit about the policy on lockdowns and express a slightly skeptical view that you probably will disagree with. So here's a view, and tell me why this is wrong. Your complaint about lockdowns is that it has massive consequences that are negative. And my view on this is, yeah, there's also at the same time literature that's found that lockdowns don't have a big effect because in the absence of lockdowns, people voluntarily social distance, and voluntary social distancing has the same consequences, a very similar consequence to lockdown. And under this view, what's really going on, or what a view that's consistent with this empirical finding, is that lockdowns are endogenous. That areas of the world that would have done a lot of voluntary social distancing are more likely to do lockdowns, and areas that would do less lockdowns. It's why we find, for example, blue states are more likely to lock down for a longer period than red states are. It's because it's what the population wants, that the government is doing the people's will in some sense, and that what lockdowns really do is just coordinate that voluntary social distancing so people are doing it at the same time. That's one view that says it's just coordinated voluntary social distancing and not coercive. What's your take on lockdowns? I
think that view is nonsense, Anup, utter nonsense, right? So I would not have voluntarily kept my kids from school for a year and a half, which is what I ended up having to do because I live in a district that does not value the education of children. I don't think that the 10 million migrant workers in India who were forced to go hundreds of miles home, 1,000 dying en route, would have voluntarily done so without forced action by the government. I don't think that people would voluntarily have lost their businesses, tens of thousands of them, hundreds of thousands of them around the country, voluntarily as a result of. I don't think that so many churches would have closed voluntarily. This was not, if it was simply voluntary action. I mean, you can look at the Google mobility data in the early days of the epidemic, and you can see this almost immediately. For the first 2 weeks after lockdown was implemented, that the idea that people reduce their mobility is absolutely true. You can see it everywhere. But after that, within 2 weeks, almost immediately, the poorer areas of the country started to see more mobility. People going back to, because they couldn't afford to stay locked down. Whereas richer parts of the country stayed locked down, even after the lockdown. The idea that you have lockdown as just a voluntary phenomenon is a phenomenon of the laptop class. The set of people who were not harmed by lockdown voluntarily locked down. They let their paranoias drive policy, harming poor people and working class people who could not afford to lock down. And they paid the cost. Their kids didn't get educated. Their ability to feed their families suffered. They're the ones that paid the harms from the lockdown, while a certain class of people, if you want to say benefited from it. The class of people who didn't, there was an NBR paper, I think that like it's about a third of the American population have jobs that could be replaced by Zoom, right? I think it's not an accident that in 2009, during the H1N1 epidemic, we did not have a lockdown. If we'd had Zoom then, we probably would have had one.
But let me pick up on that first part of your comment when we talked about schools. I think it's a topic that we still have not touched on seriously. Let's take it up. One lingering, and it's a lot. Lockdowns have diminished in frequency over time. We have very harsh lockdowns at the beginning, weaker lockdowns now, but one part that has persisted is lockdowns related to school. So remote schooling, in the United States, remote schooling lasted a year or longer. This contrasts, for example, with Europe, where you didn't see a lot of remote schooling. You saw a lot of schools still occur in person. And there are arguments on both sides of this. On the one hand, you can make an argument against it, saying this population was least impacted by COVID. The risk of death given that you have COVID increases exponentially with age, and these guys had much less risk than the elderly. It's also you could make the argument that there is inequality associated with remote schooling, that if you look at attendance rates in remote schooling for low-income populations, it's incredibly low. It's much higher for higher-income populations, so you might imagine that will increase inequality afterwards. But on the other hand, it's not only children that are in schools, there are teachers, and they're at risk, and a lot of them are working age, and sometimes the teachers or even the kids live with elderly parents or parents with comorbidities. So one thing that separates the regular lockdowns that we saw, or the early lockdowns that we saw at the beginning of the pandemic from the school lockdowns, though, is popularity. The early lockdowns are not unpopular so much, at least in blue states, whereas it seems that remote schooling, so school directed lockdowns, are unpopular across the board. Can you explain why it is that you think, despite the fact that schooling was unpopular, that it is, and the least popular lockdown across the board, it persisted for so long? Why is it that this is such a sticky policy in your mind?
Well, I think part of it is an inability for the public health community to come to terms with the evidence that was present from the very earliest days of the epidemic, that schools were not primary drivers of community spread. You could see, and in fact, the danger to teachers in schools was less than in the community at large. You can see this from data from Sweden, which kept its schools open for children 1 to 15 from the very earliest days of the epidemic, with no social distancing, no masks, nothing, just normal school in spring of 2020. The data that came out of that resulted in a New England Journal paper. The teachers were at lower risk than the average of other professions from getting COVID, and no children died during that spring. In Sweden from that. We knew very early on that schools were not a very high risk environment. Now, instead of embracing that fact, as many European countries did and many red states did, a lot of blue states persisted in the anti-scientific, the non-scientific notion that children were super spreaders. because you can think about like how we thought about you've had young kids. I've had young kids in the past. I had a cold for I don't know how many straight years when my kids were little. I mean, that's just, I think we think about kids as spreading infectious diseases to adults. That's just normal, is what we think. But it turned out, based on the scientific data, that COVID was different, at least in those early waves, that children were not particularly efficient spreaders of the disease. They got mild disease and they didn't spread the diseases efficiently. And now instead of adopting that, we went down a different path, essentially treated children as if they were disease vectors, only disease vectors, as opposed to human beings that we need to make investments in, to love and to make investments. I mean, so instead, we in many places, we closed the schools down on the basis of no scientific evidence. So now the question you asked me to speculate about why we did that. I think the root of it is fear. And I think there are political actors that exploited that fear. I don't know if they knew better or not, but they certainly exploited that fear to keep the schools closed. And I think the political costs of that are going to be enormous. You already saw some foretaste of that in the sort of by-elections in Virginia last year. I think the closing of the schools was an enormous, one of the single biggest public health mistakes I think I've ever seen. And there will be consequences to pay politically from that, I think.
So let's talk about another everything's a hot button issue with respect to COVID, but let's talk about another very hot button issue, vaccines. So my understanding, correct me if I'm wrong, is that you support vaccines, but you oppose vaccine mandates. And so I want to talk a little bit about it. Again, let me give you the pros and cons and get you to win. So the argument for mandates is an economic one. It's externalities, maybe working in two directions. If you vaccinate, but I don't vaccinate and we hang out together, I'm more likely to spread the virus, keeping the epidemic raging to other people. There's also a free riding argument, which is you're getting vaccinated protects me. And so I am less likely to get vaccinated. Maybe there's some side effects associated with it or just hassle associated with it. I'm free riding on your vaccination. In fact, people like Tom Phillipson, whom both you and I know, wrote a famous paper saying to get to 100% vaccination, you need to have subsidies or penalties because demand will decline as more and more people get vaccinated. Now, the argument against mandates presumably is autonomy, trust in government, and whether or not they're making the best judgment for you and the like. How do we know, for example, so here's my question. Well, how do we know, for example, that vaccine mandates are a bad thing, that they're any worse than, say, smoking bans, which I think most people agree have been very successful at solving collective action problem with smoking and have had tremendous health benefits? Is the problem really the vaccine mandate or the fact that things are politicized? And so even a public health decision like everybody should get vaccinated to be able to go to school or go into a restaurant, that's just become politicized. And we should look past that to see that it is a good public health measure.
So first, a couple of technical points about this, about the externality argument that are really important about this vaccine relative to vaccines more generally. Most vaccines that we have in widespread use have the property you say. So I get my kid vaccinated against measles, that my kid is not going to get measles, even if exposed. And therefore, measles, my kid is then as a dead end for the vaccine, for measles, right? They're not going to continue to spread the disease. That's not true with this vaccine. The vaccine efficacy against infection peaks around 2 or 3 months into this, based on a whole bunch of studies in places out of Israel and Qatar, Sweden, at about 60-70%, right? So 70% efficacy, that means there's still people, even at peak, getting infections that are vaccinated. I personally was vaccinated in April of 2021, and got COVID in August of 2021. Right. So it is not at all a rare event for someone who's vaccinated to get the disease and spread it. For this vaccine. The other, and you can see that with Omicron, that's happened in spades. Now, at the same time, you have people who were unvaccinated that got COVID and recovered that have better protection against infection and disease spread than the vaccinated. So the economic logic of this is in some sense inverted, right? So the positive externalities generated by the COVID recovered. Now you have to, I don't think that it's reasonable to expect people to be COVID recovered when the vaccine is available. I think it is a responsible thing to do for your own health to be vaccinated, because the vaccine protects against severe disease. If you meet COVID and you're not vaccinated, you are going to face a 10 times higher likelihood of dying than if you don't, something on that order. And so I think it is completely responsible to get vaccinated, but for your own personal health, more than for this sort of externality argument. By the time you get to 4, 5, 6 months out, the efficacy against infection drops to 20%.
So I apologize for interrupting, but I want to push back a little bit on this. So I agree with you that vaccines don't stop you from getting infected. I'm not even sure earlier vaccines stopped you from getting infected. It reduced it hastened the speed with which you clear an infection, whether it's COVID or pre-COVID. And sometimes that can actually reduce your ability to spread the infection to others. And so there is a reduced spread. It's not from you initially getting it, but from you not spreading it because you're not as infected for so long. And there's variation in efficacy across vaccines in your ability to do that. So it's not obvious that this thing doesn't at a population level reduce spread. But even put that aside, even if it didn't, let's suppose that you were right. If it's true that vaccines reduce harm, okay, and which I think you and I agree on, you want to ask yourself, is that a good idea? Now, on the one hand, you can say, no, it should be a personal decision. Do you want to face the risk of COVID or not and the side effects? And that's fine. But we live in a world where if I get sick, some of the costs of that sickness are going to be externalized onto others, either other people in my insurance pool, or if I'm on Medicaid, onto the government and whoever funds the government. And in that world where there's externalities from sickness of that sign, fiscal externalities of sickness, isn't that an argument for why it is that we might want to say, oh yeah, you gotta get the vaccine?
I think it's okay to say you got to get the vaccine. You should get the vaccine. The question is the coercive measures taken to force people to get the vaccine have undermined confidence in public health, and they've said false. People have said false. Very prominent people like Tony Fauci have said false things. People like Rochelle Walensky have said false things in service of that goal. They've said things like, well, if you're COVID recovered, that doesn't induce protection against recovery, against reinfection, right? I mean, that's just a false thing. It's just not true. They've said. Now, I don't blame them, because the evidence seemed to suggest that it was true when they first started saying it, but they've persisted long after that in saying that the vaccine protects 100% against spreading the disease. It is a fact that if you are in a room filled with COVID recovered patients, you are likely to be better protected against infection than if you're in a room filled with vaccinated patients who have never had COVID before, especially if it's been months and months since the vaccine. The direction of so let me just wrap this up. What I mean by this, if you want people to get vaccinated, you have to be trustworthy in reflecting what the data actually say. You have to come across as actually caring about the thoughts and desires of the person you're talking to. This kind of coercion, and I think in places that have had that kind of public trust, like in Sweden, for instance, you see very high levels of vaccine uptake voluntarily. Where you have this coercion, and it's a failed coercion, because ultimately you hit up against a roof that, because there's so many people that don't trust you. Even if you force people to get the vaccine, which I mean, I'm sure that's possible if you threaten their jobs, which is what we've done. There's a counter reaction in terms of loss of trust in public health that I think has enormous negative consequences going forward. I have gotten emails from many people who say that they're now distrusting the MMR vaccine, the DPT vaccine. They're distrusting the childhood vaccines. They're saying, well, now that I see that they're lying about the COVID vaccine, I'm going back and going to go look and see if I trust whether they were lying to me about these other vaccines. They weren't lying about the other vaccines. But the fact that they're worried about that is a function of this kind of resort to coercion when they didn't get their way. A better approach would have been to be actually trustworthy, to not disdain people, not to use vaccination as a political tool to divide the population.
Now, I know we're supposed to wrap this up. I'm going to ask the moderators if I'm allowed one more question. Otherwise, we'll wrap up. Do we have time for one more?
I think given the time constraints of the lunch hour, I hate to do this, but I think we have to move to student questions now. Frankly, though, this really could have gone on for 3 more hours, and I think everyone would still be just as interested as they are right now. But yeah, please join me in thanking Dr. Bhattacharya and Professor Malani. So Q&A is going to be raising your hand on Zoom, and before we do that, just a quick little request is our communications director Elle would like to take a picture of all of y'all. So Elle, take it away.
Thanks, Anson. Hello, everyone. I'm going to take a virtual photo of everyone's beautiful faces. So if you wouldn't mind turning your camera on for a minute, I'll count to 3, and then we will take a screenshot. All right, 1, 2, 3. Thanks, everyone.
Great, thanks, Elle. And it looks like our first question is from Carl Miller.
Well, thank you, Anson, and thank you, Dr. Bhattacharya and Professor Malani. Really appreciate it. My question is, you talked about the de-emphasis of natural immunity and the protection that it offers against reinfection. Why do you think it is that the public health establishment has de-emphasized early treatment?
So that is a scandal, in my view. Not because I necessarily believe that we know certain early treatments work. The scandal is we don't already know whether they work or don't work, right? So for instance, the NIH has a trial called Active-6 that's evaluating a drug called ivermectin. The FDA has tweeted out essentially like a derogatory term of calling it a horse medicine, even though has been used by billions of humans worldwide to cure parasitic diseases and has some promising results. I don't know if it works or doesn't work. There's a lot of controversy in the literature over this. There's competing meta-analyses, one which says that it does work and one which says it doesn't work that I've read on the. And so this is a first order question. If it works, we should already know. That trial is due to be done in March of 2023. We needed to invest immediately, as soon as the epidemic started, in promising early treatments. There's now a drug called fluvoxamine, which is an SSRI that apparently has shown promising results. Instead, what happened was there's actually approved drugs like monoclonal antibodies that are documented to reduce harm, especially for like the earlier variants, at least anyways. And where there's been this sort of weird underplay of them. I think part of the idea was that if I don't know about in 2020, I don't really understand why there wasn't more investment in 2020 in it. But in 2021, the denigration of early treatment, I think partly was motivated by the idea that if there is an early treatment that's available, then it would undermine demand for the vaccine. That, I think, was irresponsible. What should happen is that we should offer the vaccine and tell people the fact, which is that it protects you against severe disease. It's really, really important for your health to get it. And also offer early treatment for people who get sick and evaluate those early treatments as thoroughly as possible, as quickly as possible, rather than this very strange environment where if you are in favor of early treatment, somehow you're fringe.
Thank you.
All right, Austin.
Yeah, thank you both so much for this conversation. I really enjoyed this talk. But I guess, when we're talking about this idea of political celibacy, I guess in some ways I'm fairly sympathetic to the idea because I think that there were a lot of things done by the public health community and others, such as their statements about the protests back in May of 2020 that were fairly irresponsible. So in some ways I agree, but I do question whether or not it's even possible to get political celibacy in science. So for example, you use the example of saying that you believe that the harms of child masking outweigh benefits, but that's not a scientific question. That's a political question where we're weighing multiple values. And science can inform this discussion by telling us what the epidemiological impacts of child masking might be, what other impacts of child masking might be to their health, to their education, when we look at the psychology of education, et cetera, et cetera. But essentially the weighing of those costs and benefits is not a scientific question. And this entire talk has been a scientist talking about their opinions on various types of policy. I think that's totally fine because you're a scientist and you know what you're talking about, and I love to hear your opinion. But it does seem to fly a little bit in the face of this idea that scientists should remain politically celibate. So I kind of, question whether or not that could actually exist.
Thank you, Austin. That's a good question. A great question, actually. I should say my primary métier is health policy. So it involves science, but it also involves at its center this weighing of harms and benefits in the context of what's possible, right? So in order just to do my job, I have to do that. So I always viewed it as more important for me to be politically celibate if I could, because I'm going to be in this area where I'm going to say things that sometimes the left likes, and sometimes I'm going to say things that the right likes. And if I'm seen as coming from one side or another, which I guess now people view me as coming from one side, it would harm my ability to persuade people about reasonable trade-offs that I think everyone ought to agree about, whatever your political beliefs. I think in any area of policy, you're going to have science enter, but it will never be the final word. Political zealots, this is just an idea I had while I was talking to Anup, but I think so you can blame Anup for this, but it was as with much of everything. But I think the thing is that it's not so much the celibacy itself. It's this idea that scientists, when they're doing their craft, shouldn't be so worried about the political consequences of what they find. Scientists, when they're doing their craft and they're communicating publicly, shouldn't be so obviously disdainful of people they disagree with politically. You go on Fox News, it turns out you're a bad guy, right? That should not be a norm. And it is a norm, unfortunately, in academics, right? It should be the case that we as scientists seek respectful conversation with others, even if we disagree with them politically. I think that's really the central problem. It breeds distrust, and it makes the job of public health impossible, because the public health requires the trust of the public, all of the public, not just part of the public.
Thank you, Doctor.
And Joaquin, you have the last question. Sadly, I and many of my classmates here have class at 1:35, so hey, you'll have the last one, Joaquin. But thank you for such a great talk. Yeah.
Thank you, Anson, and thank you, Dr. Bhattacharya. I just wanted to ask, you talked about having these more, state and local level targeted responses, aimed at protecting the most vulnerable people. But are you confident that the United States, across the board are capable of putting together those responses? I think a lot of people would say that this is, maybe cynically, this is kind of what we're bad at least compared to some other highly developed countries. Unlike developing a vaccine, the investment and return trajectories, to me at least, seems less clear.
I guess my confidence in public health, local public health, has been somewhat shaken during the epidemic. Going in, I had a lot of confidence, actually, that local public health knew the communities they worked in, cared about the communities, and connected with them. I think that's really what it would have taken. And it's not even a political thing. It's just, local public health worked very, very hard to close churches, to close businesses, to enforce mandates. And that bred distrust with the people that they're supposed to be taking care of. That wasn't my experience with public health before the pandemic. Before the pandemic, I had seen local public health reach out to communities, minority communities, marginalized communities, to try to understand their needs and work with them where they were with drug addicts, to see with these harm reduction approaches to the HIV epidemic and the drug epidemics. I think local public health fully had the capacity to do it had they chosen to do so. It wouldn't have been a political thing. Like, how hard is it to ask people to, call your neighbor who's older, if you know that they're living alone, and help deliver groceries? If they ask them if they need help getting groceries over, so they don't have to go out and get groceries. And that wouldn't have been difficult, I don't think. I think Americans, we often, we like zoom between two poles. We're like the greatest nation on earth, and we're like incapable of doing anything, right? And I do think that I mean it's unfortunate that the political conversations goes that way, but I don't think of it as particularly political, or at least it shouldn't have been. Local public health, I think, knows their communities and could have worked to protect their communities if they had just chosen to do so. Instead, and I don't even blame them. I think the central public health folks like Collins and Fauci poisoned the well so that you couldn't have those conversations at all.
Sorry, just really quickly, but you mentioned something like, getting hotel rooms for people who lived in, multifamily. And do you think that the barrier to that was a mistrust of national figures like Dr. Fauci, or to me, it just seems that that is something that's more to do with local political,
No, that was just like they didn't have the idea to do it. Right. If we'd had that conversation and I mean, I wrote op-eds about it, but or op-eds where I mentioned it, but it never took off. I mean, I think it wouldn't, and that's not the right idea in some communities. It's the right idea in other communities, right? It would be it needed to be a widespread conversation, literally everywhere. How do we protect our older population? Those are the people who are dying. Those are the people who are vulnerable. That should have been the central focus. If we'd had that conversation, I think we would have done much better, Joaquin. And I hope next time we have a pandemic that we focus on the vulnerable, focus most of our resources on the vulnerable, and a conversation mostly on those, rather than trying to, rather than whatever it is the hell we did this time.
Thank you.
All right, sadly, we're out of time. Thank you for the great questions, y'all, and thank you for such an interesting talk, Dr. Bhattacharya and Professor Malani. This concludes the event, and we hope to see you on Wednesday.